Good evening, everybody. Welcome to our webinar tonight on more broadly the cortex and the spinal cord. My name is Michael. I'm finishing up my first year in neurology residency, and I have been tutoring with med school tutors for almost 4 years now. So really looking forward to covering one of my favorite, obviously, topics with you all tonight. Before we get started, I'll talk a little bit about who we are at Med School Tutors. So we are a online-based one-on-one tutoring company, really for all stages of the medical education continuum. So pre-med all the way through residency and even boards level tutoring after your residency. Sort of every tutor with Med School Tutors carries with them so many years of other tutors' experience and student successes. And the thing that links us all is that we really just love to teach. And so you can see lots of happy people down here teaching, and we'll join those ranks tonight. Other things we'll cover tonight. So I'm going to try and do a big overview of, I know everyone's the kind of the bane of the first 2 years existence. So all of the neuroanatomy that you learned, particularly up in the cortex, try and overview the important things of the spinal cord. I'll go over the tracts and hopefully some tricks for keeping them separated. We'll sort of dive in on why things are upper motor neuron and lower motor neuron and when that matters. We'll talk about how to answer questions on strokes and how you can sort of pick why is this person weak. And then I'll go over some of just a few of the spinal cord pathologies. There are quite a few people here tonight. I will do my absolute best to monitor the chat for any questions that you have. There'll be breakpoints that I've sort of built in that I will do my best to answer questions. If it gets to be too many, then I will sort of just hold them all for the end, but I promise I'll get to them. Hopefully we have a good time. All right, so I'm gonna start with the cortex, and I'm gonna start with anatomy, and then we'll do some radiology as well. So I wanted to go over each of the sort of major lobes, and then what I'll do is I'll actually draw in some more specific structures from there. And so I'll start with the frontal lobe, and it would be helpful for me if people could just type in the chat just functions that they associate with the frontal lobe. What does the frontal lobe do? Plan, execute, behavior, executive function, personality, decision-making, cognition, behavior. I agree with the entire list so far. There's a huge one that's missing though. Motor, excellent. Yeah, so let's start with the central sulcus right here, right? So this is this line here. And right in front of the central sulcus, right, we can call this the precentral gyrus. This is gonna be our motor area. And sort of the area in front of that is gonna be the supplementary motor area, right? So I'm just gonna write SMA. And then you also will see things like the premotor area. I wouldn't worry as much about what all these things do. I just know that sometimes seeing all of these words can be super overwhelming. And then everything up here, I kind of want you to think about as the prefrontal cortex. So right here in the precentral gyrus, we have our motor area, our motor strip along the whole length. We have our supplementary motor areas, which helps us with things like motor planning. And then everything that people listed, personality, executive functions, cognition, behavior, each sort of has its own little home in the prefrontal cortex. I wanted to maybe point out one area right here-ish. See if people could name that for me. Broca's area, excellent, right? And so I think that's important because Broca's area does motor speech, right? So we'll get to aphasias later. People, Broca, have difficulty producing the words. And so I want you to sort of link that with the motor function of the frontal lobe. Another area that sort of lives, again, I'm going to be off maybe by a little bit. There's no good landmarks here. Up here is our frontal eye fields and kind of helps control our gaze, right? And so this is how your eyes move when you want to move them, right? So if I tell you to look to the left and I tell you to look to the right. There's a question in the chat about remembering each area for cognition and behavior, right? So does the orbitofrontal cortex and the dorsolateral, I mean, the way that I'll answer these questions is they're clinically important to someone who's doing cognitive neurology. I've yet to find them important for students to know for step 1 or step 2. I think you can be a little more relaxed about the different areas within the frontal lobe. I sort of circled and read the ones that I would really want you to hone in on. So let's move back to the parietal lobe back here, and I'll have people sort of in the chat type in functions of the parietal lobe for me. Sensory, great. Visual agnosia, okay, interesting. Sensory. Spatiotemporal, okay. So I think what people are, yeah, so people are sort of typing in some of the deficits, absolutely. So absolutely, so right, we'll start with sensory. So right in the postcentral gyrus, right, so this area here is our sensory cortex, right? Our somatosensory cortex is gonna handle sort of the processing of all of our primary senses. And then when we get back in the parietal, I want you to think about kind of what it's close to, right? So we'll talk about the occipital lobe back here. We'll talk about the temporal lobe here. The parietal lobe I think of as integrating lots of functions, right? So paying attention to where things are in space, right? So we see things and we know where they are relatively. We hear things, we know where they are relatively. We see things and we associate with them with something else or time. So think of a lot of it as like matching our environment to sort of everything else that's going on in our brain. I know that's so broad, but maybe the easier way. We did sort of a similar, right? But if I was going to outline this area here, yeah, Wernicke's area, absolutely. So language, right? And people with Wernicke's aphasia will speak nonsense, right? They will speak words and the fluency of their language, right? So just like I am right now, they'll speak in complete sentences, but the words will sometimes be meaningless. They'll use the incorrect words, right? So when they want to say car, they'll say cat. When they want to, so they'll make paraphasic errors, they'll substitute words. And if you think about that, that should kind of make sense, right? Because this is sort of where we would integrate things. So what is the meaning of the word that we're using, as opposed to Broca's area, which would do more of the production of language. And then just to make sure that we hit all, right, these two are connected sort of, they have to speak to each other. And they do that through a structure called the arcuate fasciculus. And that is going to be clinically important to you all when you take questions for repetition, right? So that helps us repeat phrases. The point in the chat about Wernicke's was, yeah, they don't know that they're speaking nonsense. So they tend to be less bothered by it, where patients with Broca's more classically are frustrated. All right, moving back, we'll talk about the occipital lobe quickly, and we'll get a better view of it on the next slide. But main function of the occipital lobe, visual, awesome, great. And then I have nothing more to add on the occipital lobe. And then the temporal lobe, I hear auditory, hearing, totally. What else? Memory, awesome. Emotions, in part, absolutely. Memory and auditory, I think that those are great places to start. Absolutely. So this structure here that I have my mouse over is the lateral fissure, right? So the difference between a sulcus and a fissure is basically how deep it is. And so within the lateral fissure, you have things that are helpful for your auditory cortex, right? And then sort of anterior temporal lobe functions, absolutely, right? So anterior up here at the front is more where a lot of our memory structures are. And then people commenting on emotions, a lot of the deeper structures of the brain, which will be a good segue into this slide, I think are going to live in sort of the limbic cortex, which is going to be this yellow part and some of the structures in here. All right, so I just wanted to go over sort of this. So this is a sagittal cut through the brain, right into the left and right halves. We are now looking at what would be the left side of the brain from the inside, right? This structure here is the corpus callosum. This is the lateral ventricle. This, so I like imagine like not the thing that I'm outlining, but like the space here is the ventricle, the third ventricle. On the outside of the third ventricle, this structure here is the thalamus. Well, I would guess that I would maybe say that could be the amygdala. I know we were talking about some of the functions there. This is the temporal lobe, remember here on the back, the anterior temporal lobe, right? I might call this an olfactory bulb right there. Occipital cortex, the only other thing you might have to name, right, this is the calcarine fissure, so calcarine sulcus. So that's the CALCARINE associated with the occipital lobe. You see parietal, and then the frontal lobe, right, sort of all around the limbic cortex. Great. think that's probably good for naming of the cortex and function. So if you feel comfortable with that, I think you have a great starting place. A lot of anatomy, neuroanatomy in particular, and then even just studying for step one can be really overwhelming. So I want you all to feel comfortable building a really solid foundation and then just adding things as your training continues, right? Nobody expects you to be an expert right out of the gate. I would also, the analogy that I typically like with students is you have to walk before you can run. I see some people writing in about the basal ganglia, which we will get to. I wanted to show this. I think this is interesting, right? We see the ventricles in pieces. Very rarely do we see them in 3D. So this is kind of the Transformers-esque looking ventricular system that we have. And I'll pause it here, right? So this is the lateral ventricle, right? So we have two of them. And I would also, you can call them the first and second if that makes it easier for you. And you have the anterior horns. You have the occipital horns, right? That go back towards the occiput. And then you have these temporal horns. So these are all part of these lateral ventricles. I'll let it play one more time. And what we'll do is we'll pause it here. So you can see that their laterals are on the side. You have the third ventricle here, which is almost like a slit up and down. So it's going to be really hard for you to see in cross sections of the brain like this. You're just going to kind of see a thin space. And then you have the fourth ventricles here. Avery in the chat has very expertly predicted some of the names of the connections between them. So the lateral ventricles empty into the third ventricle through which structure? Foramen of Monroe, excellent. Ashin, Samantha, awesome. The third ventricle drains down into the fourth ventricle through this structure, the cerebral aqueduct. All right, and then the fourth ventricle has three ways. You can either go straight down through this one, which is called what? Foramen of Magendie, good. So the foramen of Magendie is in the midline. And then the lateral foramen of Luschka. So the M's match and the L's match. The hard one for there is Monroe and Magendie, but Magendie is midline. You're going to be more likely to be asked about these down here, I think, than Monroe. All right. And then I know it's always hard. So we can see the aqueduct, right? It's real tiny in cross section. Someone remind me what the embryologic derivative of the cerebral aqueduct is. I guess if this was multiple choice, is it telencephalon, diencephalon, mesencephalon, metencephalon, myelencephalon? Nice, Wayne. Yeah, I would agree with you. I would say that the mesencephalon. So when you study those, I know it's annoying, right? But they follow kind of nicely the pattern. The telencephalon is going to be the stuff up top here. The diencephalon is going to be stuff around the third ventricle, right? So the thalamus and the hypothalamus. The cerebral aqueduct is going to be in the midbrain. It's in the middle, the mesencephalon. And then the metencephalon is going to be the upper pons in the upper part of the fourth ventricle. And then the myelencephalon is going to be the medulla in the lower part of the fourth ventricle. So it's going to march down in order. All right. Hopefully that was helpful. I feel like we never see ventricles like this, and I really like this video. I'll quickly review. This is such a huge topic, and I didn't want to leave it out entirely, but I also wish that I could spend more time on it. The vascular supply. So I'm going to skip really the origins of all the arteries. I'm going to do another webinar on the basal ganglia and cranial nerves, and we'll cover more arteries. But I wanted to go over the big arteries, right? The PCA, the ACA, and the MCA, and just show you how much of the brain they cover. So in this view, we're sort of just rotating around the brain. We have the brainstem in the middle. It's about to pop up in a golden color. This is the PCA distribution. We're going to keep rotating. We're going to pick up the MCA in blue. So as you can see, a huge part of really I would associate the MCA for the most part. I know it looks very much up in the frontal lobe of this. I would tell you probably to say more of like temporoparietal involvement. The PCA I would sort of link to the occipital lobe, and then the ACA I would think about the frontal lobe and specifically right up here in the center. Yes, Avery, legs. Agreed, legs. Again, there are so many structures in the brain. I sort of just flipped through first aid and I was like, where would people want to make sure that we named things, and sort of just had like a quick 1 to 2 minute or 1 to 2 like sentence representation of what they do. So the limbic system, like I mentioned a couple slides ago, right, this sort of whole network of things, right, that includes things like the amygdala and the mammillary bodies and the cingulate gyrus and lots of words that you're going to see. I want you to think about the home mnemonic, right? So they're going to be helpful for things like homeostasis, olfaction, memory, and then emotions is sort of the one that I would put the most weight into. I tend to associate limbic system with emotions, right? And then that helps you with things like limbic encephalitis. So inflammation of the limbic system is going to cause people to present in ways that might look like psychiatric disease. They're going to have really severe dysregulation of their emotional system. The thalamus has tons of subnuclei. There's a couple that I'll name throughout the talk today. But think of that, it's going to relay everything, right? So predominantly sensory, but really everything. I think there's going to be motor inputs to the thalamus as well that we won't cover today and are less important, but I wanted to just, The hypothalamus, I sort of think of it like a bridge between the brain and the endocrine system, right? So particularly helpful for things involving homeostasis and hormone regulation. Basal ganglia generally is going to modulate your movements and your emotions. The cerebellum is also going to modulate your movements, and it's going to help with learning how to move, right? So remembering things like how to ride a bike. Those are going to be cerebellar. We talked about some of the language functions. Avery has commented that the basal ganglia is of the devil. I do have a trick for the basal ganglia. I did not put it in tonight, but maybe we'll do a subcortical. We'll talk about deeper structures when we do the brainstem next week. Dominant hemisphere does language, like Broca's and Wernicke's, like we pointed out. The non-dominant hemisphere for language, less important, but it's still involved, right? It does the melody, right? So my voice it's not particularly monotone. It's also sort of rising and falling as it should with normal speech. And then I mentioned the arcuate earlier. Great. You do not have to be experts on MRIs by any means. I want to point out a couple big things, right? So this is our nose, right? It's usually a helpful marker for me. I usually like to start from the bottom. Remember, when you read MRIs, it's looking up from the patient's feet. So the left side of the image is the right side of the brain. So this is the right side of the brain over here, right? And we can start to pick out some structures. So this is the medulla right here, right? And then we sort of have the cerebellum, and we have some pretty anterior aspects of the brain up here. Or no, we don't. I'm sorry, that's not brain. We'll get there in a second. But medulla, cerebellum. I'll let this run through a little bit. Great. Okay, what are these structures here? They connect the cerebellum to the pons. Peduncles, which ones? Cerebellar, good. There are 3 choices when you have cerebellar peduncles. Inferior, middle, superior. These are the middle. So we'll cover the brainstem in more detail, but if I had the pons like my fist, the middle cerebellar peduncles sort of wrap around the front, and you'll always see them as sort of a kind of like a bulge on the front of the pons. So middle cerebellar peduncles, right, are usually a helpful clinical landmark, which makes this structure in black right here the 4th ventricle, right? So the space behind the medulla before this cerebellum. Good. Now we're starting to get some of our anterior temporal lobes, right? We have our eyeballs, we have our nose. How do we know this is the pons and not the midbrain? Excellent question, because the midbrain looks like Mickey Mouse. Right, so we've rolled up a little bit. I have Mickey Mouse ears in the midbrain. I have this dot in the back, which is the cerebral aqueduct. The cerebellum is less prominent, right? We've started to pick up things like the occipital lobe, the temporal lobes, sort of at the level of the eyes. These are actually, these bright spots are the middle cerebral arteries, right? Wouldn't worry about that. It's not anatomy, but just to point stuff out. Let's keep rolling. Okay, so we've sort of lost the midbrain, right? So I'm gonna try and point out stuff I've already talked about, right? So I mentioned a ventricle that sort of is gonna look like a slit, right? So if you think about it, we've come up, we're past the aqueduct, and now I have this slit-like ventricle here in the middle. Which one is that? 3rd, awesome, good. Okay, my rule for you is when you see the 3rd ventricle, the thalamus is nearby, right? So this isn't a great frame to stop at, but awesome. Third ventricle, egg-shaped structure next to the third ventricle, no matter how you look at the brain, whether or not it's in an axial section, a coronal section, or a sagittal section. If you are near the third ventricle, the thalamus is next to it, right? You have other basal ganglia structures around there, which I'm not going to spend time naming right now, but I'll go through one more trick. Okay, great. We've started to pick up the lateral ventricles here, right? The caudate is always next to the lateral ventricles. Excellent. Dill deep, I see. Excellent. So caudate is always next to lateral. Thalamus is always next to third. That should get you a good portion through the basal ganglia each time. Frontal lobes up here, right? The central sulcus is often hard to find, and it's often farther back than I think it is. So I'm going to call this the caudate and this the caudate. And then in maroon, I'll do the thalamus. And then sort of a hard angle, but right, I would putamen, globus pallidus, it's going to be out here. Right, so putamen and globus pallidus together is the lentiform nucleus. Again, not as important, but just you'll see all these words. So cool, we'll let this run through just a little bit more. Great, we're like totally up in the cortex. MRI is hard, right? You have T1 and you have T2 imaging. Anyone want to guess which one this is? I see T1s. Yeah, I agree with you. I think this is a T1 image. All right, so they'll often tell you that if the fluid is dark, it's T1. That's almost always true. I think the thing that I tend to do is if the white matter is brighter than the gray matter, it's T1. But cool. Okay, we have no more ventricles. We're up in here, right? Mostly gray matter. Okay, I'll let it run through once more just because MRIs are awesome. So medulla, pons, midbrain. Now we have cortex, basal ganglia, frontal lobes, parietal lobes for the most part in the back now when you're up top. Excellent. All right, I think I answered all the questions as we were going, so I'm not going to pause for any more questions, and we'll do the cord now. It'll be quicker. I'm going to make sure that I'm okay on time. Great. Okay, so the spinal cord, right? There are 31 spinal nerves in total. The ones you really need to focus on are sort of these first ones, the cervical, thoracic, and lumbar. There's going to be very little clinical input for you right now for the sacral nerves. Some people like the mnemonic, right, that it's times of day that you would eat meals. I guess 8 a.m., noon, and 5 p.m. if you really wanted a nice early dinner at 5 p.m. Can help you remember how many are at each. I would tell you one of the most important things you can do to start, and hopefully this was ever taught to you when you first learned it, is you should be able to recognize the level of the cord based on the picture. That is really going to help make your life easier in the future, right? So I'll quickly talk about my drawings that I did over at the side. So at the cervical level, right, you tend to have thinner areas of gray matter, right? The H in the center tends to be a little thinner, right? You often have sort of extra divisions back here of the dorsal columns, but not always, right? You can. And then I would say those are my two big things, right? So I look for a thin H, and then the cervical cord is actually usually the biggest, right? Especially at levels like C7 and C8, it's quite big. The thoracic cord has this structure here that helps me identify it. And what information lives there? Sympathetics, awesome. Alexander, Samantha, Hannah, great, everybody. Perfect, so that's sort of how I help find the thoracic cord. And then the lumbar cord, right, tends to be much bigger, right? So I didn't really, but I kind of drew, you can see how I drew the ventral horns of the lumbar cord being much, much larger. So more gray matter compared to white matter. And if you think about it, white matter is all of the tracts that are going up towards the brain. So it should make sense that at the cervical level, all of the tracts from below are there. All of the tracts that are going to the arms are still there. So that white matter is going to be huge. And down at the lumbar cord, it's only really information coming to and from the legs that's down there. So the white matter is going to be less and the cell bodies are going to make up a larger portion. All right. So I'll always try and give you ways of like remembering things other than just memorizing them. I think that conceptually makes sense that you should have the most white matter tracts up in your neck. Another common source of confusion is that C1 through C7, the nerves are going to exit above the vertebra, and then C8 is going to be below C7. So I actually always have to draw this, right? So usually what I'll do on my paper is I'll draw C7 and T1 because I know that T8 doesn't exist. And I'll say I have 3 nerves, right? I have C7 to deal with, I have C8 to deal with, and I have T1 to deal with. So the only way that I can get all 3 of those to be in this area is to have them come off with everything above C7 being above, C8 and everything below being below their respective vertebra. All right. You need to know where the cord ends. It ends down at L1 or L2. So when we do lumbar punctures, we're going to do them at L3, L4, L4, L5, so that we don't risk hitting the cord. The end of the cord is called the conus medullaris. And then for people who are taking like step 2 or CHELP exams, that remember that the cord is slightly lower in infants. So you tend to have to do lower vertebral levels in newborn spinal taps. I don't know, I didn't draw this, right? But when I say the cord ends, right? So the cord that has the nerves coming off tapers down here at the end in the conus, right? And so it still sends nerves to lower structures, right? So if you think about it, it ends at L2, I still have L3, L4, L5, all the S, all of these are gonna come off, but they are still gonna be contained within the dural sac, right? And so this dural sac is gonna end down at S2, and this sort of tail of nerves that's not, there's no cord there, there's no sort of this structure that I drew in blue, I should have done a different color. That is called the cauda equina. Just to name things that you're gonna have seen. Great. Imaging, not gonna be super prominent for you all, I wouldn't worry too much. Just to help you orient a little bit, tricks that I find helpful. Remember C1 and C2 are combined, and then you just count. Right? So this is C1 and C2 up here, just totally combined. 3, 4, 5, 6, 7, T1, T2, T3. Sometimes it can be helpful, right? If you all feel the bulge at the back of your neck, that usually corresponds to C7. So sometimes looking on the X-ray, you can see sort of this soft tissue bulge right here on this patient. Great, and then I have a lumbar because I would be shocked if you ever needed to interpret a thoracic image, right? So I tend to think of these that are all fused. These are your sacral, right? So we have L5, 4, 3, 2, 1. You can sort of see that the cervical ones are a little like thinner and that the thoracic ones start to become a little boxier. And the lumbar ones are even boxier and bigger still. I find that to be less helpful. This is actually a T1 image of the neck. I'm going to erase what I've currently drawn on the left, right? Because you can see that this structure that I'm going to outline is the cord itself. And then you can see this black space around it. That's the CSF within the dural sac. And then if you look over here, right, the cord is dark. And then the CSF around it is bright. That's a T2 image. T2 makes CSF bright in this instance. A little harder to see on this small picture, right? But I drew L1 up to here, right? The cord sort of, maybe you can help invent this in your mind with me, sort of looks like it ends here. It becomes less like full and it kind of becomes more like wispy as you go down. That's the cauda equina. This is pathology. So I don't want you to like look at this and be like, oh, this is a totally normal, this is a spinal epidural abscess. But what level is this abscess at? L5, great, Matthew, awesome. Yeah, so it's at L5, right? So I'd be particularly concerned, right? And that's how I would just look at this. So not that you need to recognize it, but I just wanted to go over like levels and where things happen. Okay. Oops, sorry. Let me pause for questions. I think I saw one about cauda equina versus conus, and I will do that later. Okay. All of you absolutely love tracts, as I'm sure you loved memorizing these. You still remember them perfectly a year and a half after you did your first year neuroanatomy. So this is going to be really quick and not at all bothersome to anybody. So yeah, boo, yeah. Okay, that's what I figured. I'm going to just try and simplify them the best I can. So there's two that I want you to think about that are ascending, right? They are bringing information to the brain. And I also really want to point out the names tell you a lot of what they do and where they are. So there's going to be two that bring sensory information in an ascending fashion up. And there's going to be really one that I want you to know that brings motor information down. So the spinothalamic, right? So let's break it down, goes from the spine to the thalamus, and it travels in the anterolateral part of the cord, right? So those are the two names for it. And then you really just have to remember pain and temperature. I put in 3 total neurons and that'll make sense in a second. So the two names tell you kind of where it goes and where it lives. And then you just have to remember that it does pain and temperature. You're going to see things like crude touch. I find that to be less helpful, right? Distinguishing things. And then the other things that I would tell you just to maybe focus on are sort of the receptors, right? So pain tends to be carried by things like C fibers and things like that. But I thought that was a little too nitty gritty and would be better served by a table than me teaching it. The dorsal column is in the dorsal aspect of the spinal cord. And then it is the medial lemniscus when it gets to the brainstem. So we won't be covering the medial lemniscus today. It's also sometimes called the posterior column. It does vibration, proprioception, and then 2-point discrimination. So that being said, like if I put 2 like toothpicks on your hand, you'd be able to tell me that it was 2 points, right? Because you have really good 2-point discrimination there. But if I put 2 toothpicks on your back, you'd have a harder time telling me that it was 1 point or 2 points just because we're not as adept at discriminating there. So that's sort of the more fine touch mediated. Okay, and then descending, right? Movement coming from the brain coming down. It comes from the cortex to the spinal cord, right? Things in neurology are named from where they're coming from to where they're going, the corticospinal. It's also called the pyramidal system. And then you're going to see the laterocorticospinal. And that's because the anterior corticospinal tract is not as clinically relevant. Ruberspinal, you'll see it helps with movement. And then I'll cover it next week when we do the brainstem, but it can be helpful for posturing syndromes. But I just wanted to be complete here of the tracts that I think are worth your time to focus on. There are others. These are where I kind of put most of my effort. Great, let me clear my drawings. Okay, overview of the corticospinal, and then we're gonna draw. So if you have some paper, sometimes it's actually helpful to do this. So I'll name things as we go down, right? So this is my voluntary movement. So every time that I use my hand, right, it is voluntary movement. So when I use my right hand, my left motor cortex in the precentral gyrus is going to send information down, right? It's gonna send information down through the corona radiata, right? Crown of fibers. So that's all of these fibers sort of coming together. They are all going to coalesce and travel through the internal capsule, specifically the posterior part of the internal capsule, at which point all of those fibers are going to stay in a really tight bundle through the anterior part of the brainstem, which we're skipping this week. They're going to get to the medulla, they're going to cross over, and then they're going to run in the lateral part of the spinal cord, the lateral corticospinal tract. And then they're going to synapse, right? So this is one whole neuron that I'm going to draw in blue. One whole neuron, right? Cell body up here, the name, it's like the giant cell of Betz, I think is the name of the cell body, puts it off down through the internal capsule, down, 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 to the medulla. Crossover, down, 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 through the lateral aspect of the spinal cord. You see this little dot up here. Then it's going to synapse. So this was all one axon on a lower motor neuron. And we'll cover that more in a little bit. This one's probably the most important one to know all the waypoints, right? So I highlighted specifically, you need to know that this comes through the posterior limb of the internal capsule. It's helpful to remember that it kind of comes through the anterior part of the brainstem, right? These are the pyramids, that's why it's named the pyramidal tract. And then the synapse is going to be on the lower motor neuron. Okay, so this is why I wanted you to have a pencil, right? I have two aspects of cord. I want you to kind of just like draw along with me, just very briefly, right? So in particular, right, I have what level chord up here with my drawing? And then what level chord down here with my drawing? Yeah, cervical and thoracic, awesome. Right, so let's skip, oops, apologies. Skip everything from above, right? So we started in the motor cortex, we came down, we already decussated, right? The lateral corticospinal tract is gonna be always drawn out here in the lateral aspect of the cord, right? And it's gonna, I want you to think of it traveling like down in this line. Great, and then something, don't worry about where it happens, right? But something is going to synapse right here. There is another cell body that lives in the ventral horn, the anterior horn of the spinal cord. And that's gonna go out and do something on a muscle. Right, so this is gonna be our upper motor neuron, and this is gonna be our lower motor neuron. So it's actually one of the easier ones to draw and conceptualize. So as long as you remember that it crosses the medulla, we're good to go. Let's see, what else? Helpful mnemonic, right? So just to maybe refresh some of you, this is a mnemonic I remember learning for the MCAT. I'm not a mnemonic person, but sometimes I find them to be helpful, right? So the dorsal aspect of the cord, right, is back here, the ventral aspect of the cord. So you'll hear me use the word ventral and dorsal to refer to these horns, right? So this is the ventral horn, and then back here is the dorsal horn. Great, is anyone familiar with the same Dave? Same Dave. Mnemonic, maybe. So the dorsal horn does the afferents. The sensories are the afferents. So the dorsal horn does the afferent information, things coming in, and it's all sensory. The ventral horn does the motor, and it's all efferent. It's all leaving the body. So if you struggle to remember which is which and where it goes, that was a helpful one for me when I was kind of first learning it. I think once you have a more solid handle on it, you might not have to rely on that, but hey, we're all at different stages and it'll become more routine as you go. Yeah, so I shouldn't have deleted it, right? So same Dave. So this S, so the dorsal, the D is afferent, comes in, and that's sensory. So the A is how you match them. I don't know if this is a good mnemonic or not. The ventral horn, the front, is the motor, and they're both efferent, right? You use the E's to match them. All right, I skipped ahead a couple slides with my drawing. Great. Okay, so we did our descending motor. Now we have two ascending, right? And I split them into pain and temperature, and vibration and proprioception. So when you do neurology clerkships, you'll test them both in patients, right? So you'll test pain and temperature with usually a pinprick and then a cold stimulus. And then you'll test vibration with a tuning fork, and you'll vibrate it and you'll see if they can feel it. And then proprioception is whether or not they can tell where their joints are in space, right? So I'll take someone's toe and move it, ask if I'm moving it up or down. If you have bad proprioception, then you won't be able to do that. Trying to think, like, I don't have anything loud, but proprioception is like if I was dangling like my keys and they were jiggling and my eyes were closed, I could tell where my arm was in space, even though I couldn't see it, because I have a general sense of where my body is. So let's do spinothalamic first, also known as anterolateral, right? So spinothalamic tells me it's coming from the spine to the thalamus. Anterolateral tells me where it lives in the cord. So this track is probably the one that trips people up the most. And I'll follow this, and then we'll draw it, and hopefully so this information is coming from the outside, right? So let's say this is a person's foot down here. They burn it. You know what I mean? Something painful is happening. That information is going to come up through the dorsal root ganglion, which is where the cell body of sensory nerves are. It's going to come in through the dorsal horn, like we know things do. And what's weird about this one is it's going to ascend, right? So rather than let's say that this was the foot, this came in at L4 or whatever. Rather than being happy and sort of doing its thing, it's not going to do that. It's going to sort of jump around, and it's going to ascend something that's known as Lissauer's tract. and that becomes relevant here in a second. It's going to go up like, I think anywhere from up to 4 levels, but usually 2. And then it's going to synapse in the dorsal part of the spinal cord. So that first neuron did its job. It got information to the spinal cord. The second neuron is then going to carry the baton. It's going to cross. And then it's going to ascend in the anterolateral, the front, anterior, lateral, and side. This is up in the midbrain and the medulla, so don't. Oh, I'm drawing the dorsal column picture. Oh my gosh, that's so confusing. I'm so sorry. I'm drawing, these are flipped. Oh no. Ah. See, that's why you have to know the anatomy, because you could have been like, Michael, these are flipped. But all right, ignore this. This writing is for the dorsal column. This is for the anterolateral. But the drawing I did was still the same. I apologize, everybody. So we're sticking with spinothalamic, right? So this information over here comes in, does the little ascend thing, still synapses, that one carries it across, runs it all the way up the front and the side. Then it makes it to the thalamus, and the thalamus sends the third neuron to the sensory cortex. Okay, so there's 3 neurons, right? Comes in, ascends, synapses, carries across, runs up, synapses in the thalamus, goes. And so I colored them as they match the picture. The dorsal column is a little different, right? So I'm testing your right-left confusion here by going to this other side. So the same thing, peripheral synapse comes in, but instead of crossing, this one's just going to run up immediately, right? And it's not going to hand off the baton. So this first nerve is going to do more, right? So remember, this one handed off the baton in the cord. This one's going to carry all the way up to the medulla, right? So the nucleus gracilis and cuneatus, which are going to help name some things, but it basically it's just the 2 names and helps you with arms and legs. But going to hand off there in the medulla, and then that is going to cross and then run up to the thalamus. And then so the pathway from the thalamus to the cortex for both is the same, right? So you can see that I have in the purple text, both of them are going to go from the thalamus to the cortex. So both of them have to get to the same place, right? If this is my left foot down here that I hurt, the difference is the dorsal column is going to run that information up the left side of the cord, cross in the brainstem, and then make it to the right brain. Versus the spinothalamic tract, over for my left foot, is going to cross immediately and then run it up the right side of the cord and then make it into the right side of the brain. So that's where it bothers people. And it does not help that I mix them, but I will fix that. Okay, let's draw dorsal columns first, just to illustrate the same thing that right? So we're going to say that I had sensory input come in from my leg, or this is the thoracic cord, but still, wherever, right? It would enter here, and the same neuron would already start running up the dorsal column, right? So there's no synapse, so it's gonna run up, and technically the leg is the outer one. No, the leg is the inner one. They feed in. So the leg is going to be here. We're going to get up to the medulla, and we're going to cross over. In a different color, we're going to do the pain and temperature. So I'll do pain here in green. This is where it'd be helpful just for the motor act of drawing. It might help you remember it. This one's going to come in. It's going to ascend like 1 or 2 levels, and it's going to synapse immediately, right? It's going to pass the baton. So I'm going to draw a new nerve here. They're synapsing back here in the, this one is going to cross through this structure in front of the canal, the anterior white commissure, and it effectively is going to make it up here into the anterolateral cord, and then it's going to ascend in the anterolateral cord, and then it's going to make it up to the right side. And then both of them are going to make it to the thalamus, and the thalamus does all the job from there. Okay. Dorsal vibration proprioception ascends before it decussates. Great. Spinothalamic pain and temperature decussates and then ascends. Totally. absolutely. All right, let's clear these. One more drawing. I know this is kind of clunky, but I have to draw this. Okay, so let's do everything regarding this person's right foot, right? So no matter what, movement, pain, temperature, vibration is all going to, for this person's right foot, so down here, is all going to be controlled by the left part of the brain, right? We know that to be true. So no matter what, we have to get from left to right. I actually think that most students find the corticospinal tract to be the easiest. All right, so I'm going to start with that. So I'm going to start with information. The first neuron is going to start up top in the motor cortex. And so I'm not going to have great spatial resolution this way, but it's going to go down. It's going to make it to the medulla. It's going to cross, right? It's going to decussate in the medulla. And then it's going to make it down to the end of the spinal cord, synapse, and then it's going to control that person's right foot. I'm sorry, yeah, their right foot. Great. Here's why I like to start with this, right? So if I name this the corticospinal tract, if you think about it, the dorsal column is going to follow effectively the exact same pathway. So they're going to go together. It's just kind of in reverse. I'll draw them appropriately, and then hopefully you see that the lines are very similar. So the dorsal column, so I'm going to draw the cell body starting down here, putting a vibration sensation on this person's foot. The peripheral nerve is going to take it in. It's actually going to run it itself all the way up to the medulla. It's going to synapse. I'll use like a light green. That synapse neuron is going to bring it across to the thalamus. And then, I don't know, I'll use like a purple for thalamus to cortex. So you can see that these two actually like run together. So if you are just like, I have the mental capacity, Michael, to remember one of these, remember the corticospinal, and then remember that the dorsal column looks effectively the same. And that might help you navigate through most questions, right? And you're like, great, I have the mental energy to remember that much neurology, just start there. And you can remember that the other one is just different, right? So if someone has when we start talking about cord problems, right? If I cut this person's spinal cord here, right, the vibration deficits should always be the same as the upper motor neuron deficits, right? So you see that these two run together. They should almost always produce the same problems. The exception is in the brainstem. And now let's do pain and temperature, right? So the one that sort of behaves a little bit differently. So I'm going to draw the same cell body, right? A different nerve is going to bring it in. And I sort of said that it's going to kind of like ascend a little bit, and then it's going to synapse in the cord. A different nerve is going to pick up the baton, cross over through the anterior right commissure, make its way up to the thalamus, synapse on that same purple neuron, and then that's going to be the third one. Right. So now you can see when you start answering questions like we're going to do later about somebody who has a spinal cord lesion, right? If I hurt the right side of this person's spinal cord, it's going to affect, right, my blue and my green pathways. So my corticospinal tract and my dorsal columns. It's not going to affect pain and temperature on the right side. It will affect the pain and temperature fibers from the other side, right? So I'm going to draw them the mimicking pink. So that's where you're going to get crossed body signs. Does anybody need me to go over that again? Right, so if I cut through the right portion of this spinal cord, you can see how it's going to impact the blue and the green pathway, right? So the motor coming down that's green, the vibrations coming up that's blue. It's going to spare the right-sided pain and temperature. But you have to sort of imagine in your mind that there's also, right, left-sided pain and temperature that's kind of following the parallel pink pathway. And that would be affected. Great. Okay. Yeah, so if you're simplifying it, right, of right-sided spinal cord, and you're like, okay, great, I remember corticospinal, I know dorsal column follows the same, and I know spinothalmic is the opposite. That's gonna get you through places in the cord. Okay, these are exhausting, but hopefully everyone feels a little better about them. Great, let me clear my drawings. All right, let's briefly discuss like an upper motor neuron versus a lower motor neuron and kind of what that looks like. I'm a little behind time, so I'll go a little bit easier here. All right, I drew a cord. I have a leg, and this is my favorite way of teaching this, right? So I'm gonna draw two muscles, right? I'm gonna draw someone's quad muscle here, and I'm gonna draw someone's hamstring muscle here. So what I want you to remember about reflexes is that they're independent of the brain, right? So you're gonna hear about synapses and circuits and stuff. So when this person's leg, so I want you to kind of picture the leg out straight, the quad and the tendon is like kind of relaxed, right? But when this person's leg is bent, this quadriceps tendon is as stretched as it ever wants to be, right? It is stretched out, right? You can think about it like kind of bent over the patella and like attaching down here at the tibia, right? So this is really long. It's at max stress. If I then tap it with a hammer and indent it, that makes it longer, right? So then a couple things happen, right? So this is now sensing that it is far too long. So that information is going to do a couple things, right? It's going to send signal to contract, right, to shorten it. And then it's going to send signal to sort of help with the backside to help and things like that. So I don't want you to worry as much, but that's in general why we have reflexes, right? So the tendon is too long, you compress it and stretch it. So the reflex is to shorten the tendon. This is all controlled in a local circuit, right? So this nerve communicates directly in the spinal cord and says it's too long, right? So there's no input from the brain whatsoever, right? I'll just simplify it and draw a circle out like that. The job of our brain is to keep this circuit chilled out, right? To keep it under control. So I'm going to refer to the brain here as very inhibitory, right? Because that prevents like sometimes I'm like, right, if you think about it, you can suppress reflexes. I'm using this to mimic my knee. If you sat there and you thought about it and someone tapped your reflex hammer, it wouldn't go because you can sort of turn it off voluntarily and then you involuntarily turn it off all the time. So this is a suppressive nature. This is the upper motor neuron, right? So this is the corticospinal tract neuron that when it's not voluntarily doing stuff is suppressing these sort of reflex circuits from working. So the reason that I wanted to do this is if you think about when this breaks, right? So if I broke the upper motor neuron, this goes wild, right? This reflex circuit goes all the time. So I'm hyperreflexic. These nerves are firing more often than they should be. So the tone of the muscle, right? If you think of a clenched muscle, is more than it should be. But I don't have great control over the limb, so it's still going to be weak. Right? So that's how I like to think about upper motor neuron. Versus if I broke these down here, right, the lower motor neurons, no matter what I do, it's not going to work. The reflex, the ability to have a reflex is going to be disrupted. This muscle is going to be starving for any kind of input, so it's going to atrophy, it's going to shrivel up. All right, we'll fill in a table on the next slide. So let's go through that again, right? So the bulk, how much strength the muscle has, is going to be down, right, in a lower motor neuron, because the nerve itself is never talking to the muscle. The muscle gets mad and shrivels. Upper motor neuron, we'll call it normal, right? The muscle's not going to get bigger, right? But it's not necessarily going to shrink because it's getting input. The tone, how like taut and tight the muscle is also going to be down a lower motor neuron. It's got no input. It's just sitting there. And an upper motor neuron, right? Remember the nerve stimulation is going crazy. So the tone is going to be up. The power, how strong it is going to be low in both because either I can't control it from the upper or I can't really execute it with the lower. Reflexes are going to be low and lower. They're going to be high in uppers. Fasciculations and fibrillations, these are lower motor neuron signs. And so what I want you to think about, and I'll draw it here, is a muscle, right? Normally my muscle has its little nerve friend that provides it with some stimulation here and there. This is the lower motor neuron, remember? If this lower motor neuron, if this goes away, this muscle is going to start doing stuff by itself, right? It's not stimulated. It's kind of like a kid that you just like locked in a room. It's going to start doing crazy stuff. So it's going to fasciculate, which is twitch to the point where you can see it with your eye. And it's going to fibrillate, which is where you can only see on an electrical level. So think of the muscle that has no nerve innervation. That is going to fasciculate, fibrillate. That's the muscle sort of trying to contract all on its own. It's uncoordinated. It looks weird. Upper motor neuron lesions don't do that, right? Because remember, the lower motor neuron is still touching it. It's still communicating. So the muscle itself isn't going to go crazy. Localization, so where does this normally happen, right? So lower motor neuron weakness, if someone looks like it, right? So the nerve itself, right? The plexus of nerves could totally do it. The muscle itself, right? It's all gonna make someone look low bulk, low tone, low power, low reflexes. Whereas the upper motor neurons, right? I normally think of the spinal cord, the brain, right? So, okay, questions on that? Great, speed through. Important reflexes, things to remember. So your biceps reflex right here, C5, right? So if they tell you that someone has no biceps reflex, the answer is C5. They tell you someone has no triceps reflex, the answer is C7. No patella reflex is L4, it's a femoral nerve. No Achilles reflex is S1. Caveat for those of you who are step 2 or just clinically, most people who have had 60 or 70 or more birthdays don't have their Achilles reflexes anymore. Cremasteric reflex, I've never seen people test clinically, important for testicular torsion. L1, L2, which is the genitofemoral nerve. You see the buzzword for somebody who has absent reflexes that are absent in an ascending pattern. So they lose their ankle reflexes and then they lose their patella reflexes. What disease do they have? Guillain-Barré, awesome. Yeah. So 2 weeks after viral URI, GI illness, ascending hyporeflexia or areflexia, you spinal tap them. They have protein, but no white cells. They have albuminocytologic dissociation. Then they have Guillain-Barré. Buzzword, delayed relaxation of deep tendon reflexes. Ooh, I maybe stumped people. Maybe this isn't as specific as I think it is. So calcium disorders absolutely mess with your reflexes because if you think about it, they mess with muscles. Chitra, very good. Thyroid. Yeah, so this is kind of the classic description for hypothyroidism, right? Their sluggishly slowed relaxation of DTRs is, if you see that is a good clue for hypothyroid. That's how the boards like to describe it. On the opposite, hyperreflexia, right? If someone has widespread hyperreflexia, things like hyperthyroidism are absolutely on the differential. So hypothyroid slows reflexes, hyper raises them. All right, if somebody has 3+ reflexes in their lower extremities and 1+ in their upper extremities, where's the problem? Wayne says ALS, which is a good guess, it's reasonable. I can sort of dispute it though. There could be another option, right? You'd hate to diagnose someone with ALS just based on this, because it could be explained by something else. So what I want you to kind of think about is if I had a problem with my cervical spinal cord, right, at the level of my arms, I would have hyporeflexia in my arms, right? I'd be 1+, lower motor neuron problems there. But if it involved the upper motor neurons, right, the whole cord, I would have problems below. So I'd have hyperreflexia there. Does that make sense? So usually if someone has lowers here and uppers below, it's probably in their neck. But if someone has low in their legs and then they're hyperreflexic, that pattern doesn't really fit. So that's when I would worry about like ALS. Avery's asking about Brown-Séquard, which we will do. Hans asking about Syringomyelia, which we will also do. All right, I'm gonna do speedier. Okay, so I wanted to briefly touch on how to use the corticospinal tract to help you with strokes. Okay, a 78-year-old female, she's diabetes, she's hypertension, she has coronary artery disease, she has acute onset weakness of her entire right side. So she has no other problems. Where's her stroke? So I see Left, perfect, that's fine. I love if you start with left. Okay, I see internal capsule and I see MCA. Which one's right? Which one's correct? Internal capsule is correct. So why is MCA wrong? MCA only does the arms and face. MCA only does the face and uppers. That's fair. Okay, so what I want you to start to think about is when you see someone who has this much symptoms, right? So for you to have a stroke that did the legs, arms, and face, right, it would have to do this whole part of the brain, right? And we already mentioned that it would be like a lot of the ACA and the MCA to do all of that. Does the fact that it's the right side of her body matter? I guess my point is, if this person had a stroke that was this big, what else would be impaired? On the left side of her brain. Language, speech, awesome, right? She has no other deficit. She has no speech and language problems. So that actually probably tells you that it's not the MCA, right? It's not the motor cortex. So that's a helpful clue, right? So start to pay attention to what patients don't have. And then, right, so looking at it, the homunculus, right? So it would need to be all of these. And then if I was telling you that you had to knock out all of them, remember you have the corona radiata, and then they all coalesce into like a super tiny little part in the posterior limb of the internal capsule. So if I had to tell you to break some, like to weaken somebody's leg, their hand, and their face, this is a way easier spot rather than doing this whole side, right? Matthew brings up homonymous hemianopia. So I can sort of take this maybe as a little bit of a segue. There are things that your cortex does that the inside of your brain doesn't, right? So both of them have motor. So if you think about it, the motor it travels from here and it goes down through the deep parts of the brain. But your outside of the brain does things like language, right, which would be spared in an internal capsule stroke. Remember, fibers for vision run through the parietal and temporal lobe, so those can get impacted. And then the other parietal lobe does neglect, right? So some people like the mnemonic VAN, V-A-N. If the person has visual deficits, aphasia, or neglect, it's more likely to be a stroke out here, right? And less likely to be something deep like the internal capsule. So the correct answer for this patient who just has the entire right side of her body and has no other symptoms is going to probably most likely be the left posterior internal capsule. Cool. Does that make sense? Hopefully, there's so many questions on this for step 2 and step 1 about like the person is weak and where is it MCA, is it internal capsule? I think this is a nice way of thinking about it. And they're almost always gonna be right-sided patients because they want you to recognize that there's no language problem or there is a language problem. All right, and then I just had that to refresh. Okay, predict this person's symptoms. This is a right-handed person and I broke this part of their brain. Van mnemonic tells you either cortex, right? So remember, you can have visual language symptoms on one side, neglect was part of Van, that can be on the other side, and then the visual could be either. N is for neglect, correct. Okay. Yeah, so I'm seeing tons of stuff, right? So this is a parietal, right? So we're kind of stroking. So this person is right-handed, right? And that matters because it means the left side of their brain is dominant. We're looking at the right side of someone's brain. So this person is having a non-dominant parietal stroke. So when I say that, neglect, awesome. Yeah, so the kind of the classic stroke syndrome of a non-dominant parietal, right? So you see things like right-handed and then the way that I have the picture oriented kind of matter. So neglect means that they're not going to pay attention to that side of their, right? So they put makeup on half their face. They're going to eat half the food on their plate. You can put someone's hand in front of their face and ask them what it is and they'll be like, that's your hand, right? They don't pay attention to that side of space, but they can see it. It's strange. I like the answer about sensory loss on the left. I am less keen on the answer about language loss, right? I would maybe, right, non-dominant language. 99% of people who are right-handed have left-sided language control. So I'm less keen on the language answer, but everything else, I think that was in the chat, I agree with. Okay. Let's do this one. The right-handed patient. Should be a little faster, right? It's just same brain flipped. Yeah, Wernicke's aphasia, awesome, right? So we're involving sort of this area right above the lateral fissure, right? Parietal, right? We're gonna have mostly language issues here. Totally agree, okay? Person is right-handed and has a lesion here. This is mean. It's not that mean. I'll accept 2 answers. Ataxia, excellent. I see Grantsman syndrome. I'm less familiar. Are you possibly referring to Gerstmann syndrome? Gerstmann's, yeah. So Gerstmann's, I tend to think of more of like a dominant parietal, right? And it has the weird 4 things that I can never remember: right-left disorientation, finger agnosia, acalcula. They can't do math. Right, left, finger agnosia, acalcula. There's one more. I don't remember. There's one more, but agraphia, sure. Oh, that's right, agraphia. Okay, so this person, so I would accept, right? So I just want you, I think this is actually the left cerebellum. And the reason that I'm going to make that claim is if you look at, right, we have the midbrain right here, and then the structure above it is the optic chiasm, right? So we're looking up at the brain. So I think this is actually the left side of the cerebellum, and it's out on the outside. So they would have left-sided ataxia. As long as you knew that it was ataxia and that you knew it was a cerebellum, I think the orientation of the image is too mean. You wouldn't ever see a test like that. But right, these are the olfactory bulbs. We're looking at the underside of this brain. Again, I think a really mean test question author could do this, but okay. Patient is right-handed and has a bilateral lesion of these structures. Yeah, they're the mammillary bodies, great. Mammillary bodies does Wernicke's encephalopathy, awesome. And the triad of Wernicke's encephalopathy is ataxia, encephalopathy, right? And ophthalmoplegia, right? So eye movement problems, good. And then if it becomes long-standing and untreated, it becomes Korsakoff syndrome, which is then characterized by confabulation, right? Classically caused by thiamine deficiency, which on step 1 is almost universally in the setting of alcohol use disorder. On step 2, sometimes they'll give you, you can get thiamine deficiency from hyperemesis gravidarum in a first trimester pregnancy. I'm getting really nice tan lines from the sun setting right now. Okay, cool. Spinal cord path, I'll sort of move through. I love this picture. Disc rupture, right? So it's the herniation of the nucleus pulposus, the center part, through the annulus fibrosus, the rougher outer part. Remember, the nucleus pulposus, they like this, is an embryonic derivative of the notochord, right? So that herniates through and then it can compress. The cheat is, they'll always ask you like, oh, this is gonna affect which nerve? It's always the second one, right? So if it's a C6, C7, it affects C7. If it's an L5S1, it affects S1. So you can just remember that. It's almost always the second one. That's the trick. The actual explanation, right? So the nerves tend to be flatter and the discs tend to be, the vertebrae tend to be shorter, right? So if you look here, I have the C5 vertebra, I have the C6 vertebra, and the C6 nerve kind of comes off like nice and flat there. So if I have a C5, C6 disc herniation, it's going to pinch the C6 nerve. Whereas in the lumbar spine, they like sort of come off and they like travel out like pretty quickly. So at L4, the L4 nerve really already has left even before I get to the disc. The L4, L5 disc is going to pinch the L5 nerve. Right, so you can see almost all herniations are going to be paracentral to someone's point. If they herniate in a really weird way, like out to the sides, they can clip the same side. But does that make sense? So the quick way is just whatever the second nerve is, that's what's being impacted. This is sort of the anatomy on why. Someone mentioned this earlier, a syrinx, right? So that just means a fluid-filled cavity. If it happens in the spinal cord, myelia is the root for spinal cord, right? So this means fluid-filled cavity in the spinal cord. The central canal tends to almost always in the cervical cord, so you're not going to see these in the thoracic and lumbar cords. If it's in the brainstem, it's syringobulbia. Bulbar means brainstem. The classic patient, right? So if you see the 30-year-old person who burns their hands while cooking in the kitchen and they can't feel it, that's the one-liner typically. Yeah, cape-like distribution. Awesome, Avery. As it dilates, it's going to first impact the anterior commissure, right? So remember earlier we talked about how the fibers of the spinothalmic tract come in, they synapse, they hand off the baton to the next one that runs across, and then it'll ascend up on the side. So you can see as this thing swells, the first thing that it's going to pick off are the bilateral crossing fibers of the spinothalmic tract. So you're going to lose those at the level, right? So kind of a cape. You're not necessarily going to lose all the stuff below because that's already safely running out here in the anterolateral system, right? It's really just going to be the fibers that cross at that level. So that's why you're going to get the cape-like. As the swelling progresses, and typically, clinically, I've seen very few of these be super progressive, and then on text questions, right? The next thing that sort of gets picked off, and I don't want you to be confused by, is the anterior horns. The patients can have lower motor neuron symptoms at the level. Does that make sense? The etiologies, I think most of them are in the setting of people who have Chiari malformations, right? Sort of just like herniates the cerebellum down through, the cord gets a little weird, tends to swell and dilate, and then people can get them post-traumatic. Cape-like effect means that it's going to affect the pattern that a cape would. It's going to be along my arms, right? So people are going to have hand symptoms. I'm going to tilt my blinds real quick. I apologize. Great. And that's not much better, but all right. Okay, predict this person's deficits. We have 2 more slides for people who are like, okay, how much more do we have? So you're like, okay, Michael, how would I even begin to do this, right? What's the first thing that I told you earlier? I want you to figure out what level of the spinal cord we're at. Great, Matthew, we're at the thoracic spinal cord. Awesome. Okay, so that should be helpful, right? So we have sort of this intermediary column right here. Okay, and so now I just think if you're like, okay, great, what do I do next? Just think in the setting of each of the 3 tracts, right? So tell me on the right side of the spinal cord where like the motor findings would be. Ipsilateral motor, awesome, right? So we talked about corticospinal tract is already crossed by the time we get to the thoracic spinal cord. It's going to be upper motor neuron symptoms below. So upper motor neurons in our legs probably. What did I say about the dorsal columns? They always do the same side. So I'm going to have vibration and proprioception loss below. I'm going to have loss of pain and temperature contralaterally because those have crossed already by the time they get there. And then someone asked this question earlier and I ignored it, but I was not ignoring you because I knew it was going to pop up here. You possibly can lose pain and temperature at the level of a cord lesion because, right, you impede the ability to get in the dorsal aspect. Avery, I'm sorry, I was not ignoring you. Great. So I didn't read everyone's answers as they were coming in, but I have all the correct answers here on the screen. Great, so loss of pain and temp, upper motor pass on the weak below the level, vibration and proprioception on the right, below the level. And then remember that pain and temperature is gonna be like 1 or 2 levels below because it would have crossed and come up. Cool. Okay, these are escalating hardness. So for this first cord, I want you to predict someone with an Argyll-Robertson pupil. So we'll do this in 2 steps. What does that mean? What's their diagnosis? Syphilis, great. What part of the cord does syphilis tend to affect? Posterior columns, awesome, right? So this person who has an Argyll-Robertson pupil at this level of the cord, I would expect to have vibration proprioception loss throughout. Great, okay. Someone with a type B aortic dissection that affects the artery of Adamkiewicz. Everyone's like, what? So remember at the thoracic cord, yeah, anterior spinal artery, awesome, right? So Samantha, excellent. So everything except for the dorsal columns, the anterior spinal artery is going to do this pattern here. So remember, an aortic dissection, as it goes down, can sort of impact arteries that come off of it. The artery of Adamkiewicz feeds the thoracic spinal cord, the anterior spinal artery. So if you dissect, it lowers that. Your thoracic spinal cord has really poor collateral blood supply. So you can have an anterior spinal artery infarct. Abdominal surgery, yeah, totally. Systemic, like there's a couple things that can be risk factors here. All right, someone with a diphyllobothrum latum tapeworm. Okay, great. See, everyone, this is step one is the worst because has this ever happened in real life? I don't know, probably. Has anyone ever seen it? Maybe. So B12 deficiency can be induced by lots of things, right? Pernicious anemia, strict vegan diet, and then the rare one is the diphyllobothrum latum tapeworm. B12 deficiency causes subacute combined degeneration, right? So subacute and combined should make you think that it's slow, it's subacute. Combined means it's two things. It tends to affect the dorsal columns, but I don't need to forget that it also affects the lateral corticospinal tract, right? So this is sort of the classic pattern of a B12 deficiency. So they can have upper motor neuron weakness below, it's usually in the cervix, right below, so in their body, and then the vibration and proprioception, but they have intact pain and vibration up here. I'm sorry, pain and temperature. Whew. All right. That's it. So a couple things to wrap up, right? One, as you can see, I love teaching neurology and I went way over because it's just so fun to talk about. All of our tutors love to teach and do things in ways like this. Additional things that are kind of offered through MST, right? So custom study schedules, like when I meet with students, we talk about their schedule and we do teaching like this, but also how to approach USMLE style questions. Work with you kind of through the whole process, and then even things like consulting for applications. Okay, I will take more questions. I think I followed a lot of them as we went. If I missed your question to date, I don't have it in my mind, so please retype it. Additionally, I know people are like, oh, the basal ganglia is the devil. Like, I'm planning on doing brainstem and cranial nerves and like a couple of things next week at the same time. But if there's more things that I should add, like I think visual pathways is probably something important that I didn't cover here that I would have liked to have covered. Okay. Okay, what is the difference between the vermis of the cerebellum and the difference? Great question. All right, so I'm going to draw a cerebellum over here. Right, so the vermis is the midline. Cerebellar hemispheres go out, and then you have like the weird, like under, like the flocculonodular lobe, but I wouldn't worry about that clinically, so I'm going to get rid of it. So the hemispheres, the outside, the right and the left, they do control of the limbs on that side, right? So someone with a tumor here is going to have left-sided dysmetria. Remember, it does not cross. Someone with a tumor here could have right-sided dysdiadochokinesia. The vermis does stuff in the middle. So those people will have truncal ataxia, right? Inability to kind of sit up in a chair. And then remember, your eyes are also in the middle. So these people can have nystagmus. So the classic findings, right, are going to be nystagmus and truncal ataxia. Remember, alcohol is a toxin. Alcohol will preferentially destroy the cerebellar vermis. So if someone with long-standing alcohol use, those are people who get vermis problems. The only other thing that I can think of is pediatric brain tumors, astrocytomas, and medulloblastomas both affect the cerebellum. So the pilocytic astrocytomas are almost always in questions going to be lateral. So if you see a kid that has ataxia and stuff like that, I would already tell you it's probably more likely to be a pilocytic. If it's midline, I think medulloblastoma. And remember, the fourth ventricle kind of lives here. So that tends to compress the fourth ventricle, cause midline stuff, and it's a much worse tumor. Describe what at the level means. Great, yeah. So if I'm at like the L1, L2 vertebra, right? And I hurt, I'm gonna pick different ones that I know more about, right? So let's pick L4, L5, which is more common, right? And I hurt the L4 nerve, right? Or the L5 nerve, or whatever I hurt. Right? Let's say I hurt the L5 nerve. So the L5 nerve is super important for some of the muscles in our leg, right? So it's particularly important for like people's ability to like walk on their heels and walk on their toes, and these people might have a foot drop, right? So when I say that it's at that level, I mean that L5 is going to be impacted. Anterior horn lesions are lower motor neuron always. Anterior horn and ventral horn lesions are the same. Right, so if I'm drawing an H, it's really bad. Oh, wow, that's really bad, right? This is the anterior horn of the ventral horn. The lower motor neuron cell body lives here and leaves, right? So if I break the anterior horn, I effectively break the lower motor neuron. This study session is based on probably mostly step 1. I think the anatomy is super clinically relevant. Pro tip, neuroblastomas in the kidney, not the brain. Yeah, that's a good pro tip. Brainstem cramming. Oh, wow. The rule of 4s, there's really only one rule of 4 here. This is very, right? The midbrain, the pons, I will draw like a bubble, and then the medulla sort of like tapers off. There are 4 cranial nerves in the pons, and that's 5 through 8, 5, 6, 7, 8. There are 4 above, 3 and 4 live in the midbrain, 1 and 2 are above, and then there are 4 below, right? So the 12 cranial nerves, and that's 9, 10, and 12, and technically 11 is in the cervical cord. So if you have to figure out where something is in the brainstem and they have a cranial nerve 3 palsy, the answer is in the midbrain. If it's a 6 palsy, it's in the pons. If it's a 9, 10, 12, it's in the medulla. That's probably the best brainstem. That gets you through a lot of stuff. Ooh, CMT versus CIDP. That's a pretty nuanced question. Remember, Charcot-Marie tooth is usually an inherited and genetic question. They're going to be more likely to have other descriptions like things like hammer toes, right? So the nerves degenerate and that don't supply the muscles in the feet. So the feet have kind of abnormal arches and hammer toes, versus CIDP is recurrent. Think of it like recurrent Guillain-Barré. So they get recurrent bouts of inflammation that's going to cause sort of the same picture of ascending. There's variants of CIDP that are far beyond step 1 and step 2 level content. Okay. Anterior horn syndrome looks like lower motor neuron. Headquarters, yes. These last few chats, I will factor all these in as I continue to fine tune for next week. All right, this was super fun. Thank you all for being here. I hope you have a good rest of your night and good studies.